From a GP workforce perspective, Yorkshire and Humber is one of the areas that really struggle to recruit GPs. So if we think about how well we recruit to GP training schemes, if you look at most of the areas in the home counties, in the South East, Oxford, Cambridgeshire, that sort of area, they recruit 100%, they fill their schemes 100%. If we look at Yorkshire and the Humber as a whole, it's 80%. If you look at Hull, it's 30%. Scarborough didn't have anybody, 0. And this year in Yorkshire and Humber so far in GP recruitment, we've got 27 people out of a target of 100. Our practice, we serve 50,000 patients across the two cities. And we've been on a journey for the last decade. And this is the organisational structure. It's a little bit complex, but we started off as a partnership in York. When I joined in 2002, we had 20,000 patients, 4 sites. So we decided after the new GMS contract in 04 or 05 that there was threats to general practice and that we needed to diversify to protect ourselves. And we decided to be a medical business with general practice at its core. And what we did was we looked around for opportunities. It was about the time of the Lord Darcy reviews and the Equitable Access to General Practice scheme, you'll remember that, some of you maybe, where they tried to focus on underdoctored areas and create new practices de novo. And we formed a limited company and we bid, so that's Haxby, imaginatively titled Haxby Business Group Limited, and we bid for 3 APMS contracts. No help, no support, did it at risk, and we won 3 contracts. And in the back end of 08, 09, we opened 3 practices with no patients in Hull, strange city, 40 miles away. Why did we go to Hull? Well, because they were underdoctored and because the Joint Strategic Needs Assessment in the Public Health Report tells us that their life expectancy was 10 years less than people in York. The prevalence of all chronic conditions, long-term conditions, was significantly higher. Smoking was higher, unwanted pregnancy was higher, cancer was higher. It just felt like the right thing to do. It was an ethical way to grow and diversify. So we did that, and then we ventured into pharmacy, so created another limited company, partnered with a pharmacist, and opened 300-hour pharmacies. And back then you could just open them. There wasn't any contractual barriers to doing that. And of course, in each city, we're involved in collaboratives, so federations, whatever you want to call it, alliances with other practices to deliver care in a different way. So that's the capitation. I've talked about that already. We've got 9 sites, 6 in York, 3 in Hull. Underneath all of that growth, we've developed delegated management structures, and I'm sure those of you in general practice have seen these things crop up all the time. So we've got our own finance team that sits across the 3 businesses. We've got our own HR function, dedicated function. We've got secretarial and admin functions, but we've got this, and this is really important. This is what used to be called data, our data team. So when I joined back in the day, when QOF started, we had 1 person doing this in the back of the building somewhere in a little office, crunching numbers all day long. And as we've grown and developed, this has grown with it. So up to 2015, we went from between 2009 and 2015, we went from 1 person to 7 people. Is that 7? Yeah. 7 people spread across the 2 cities. And then when we merged in 2015 and the patient numbers were growing sufficiently in Hull, we went to that. So now there's 18 people, and we're not data team anymore, we call it business intelligence. It's a bit grandiose, but the difference is this is using data not just to trigger payments. This is not just about making sure we claim for all the enhanced services that we do. This is about driving the business and using data to shape what we do in everything we do. And it's been massive. It really has helped us just view things in a different way. It's kind of professionalised it. You know, we're not doing research trials here. This is turning the OODA loop, turning the PDSA cycle quickly. We can come up with ideas. They don't have to be perfect when we start them. The data team jump into action. We decide what we're measuring, and we're reviewing it constantly and tweaking it constantly. And it feels really positive. And underlying that, we've created training manuals, business support manuals. So all our we have lots of apprentices that come into that team, and we train them up from school leavers, and that's what you want with data, and they're kind of brighter at that sort of thing and more used to that sort of thing than we are, and they've helped develop all of this, and so they get standardized training, standardized approach, and it works really well. So before I get on to some of the things that we've created internally. I'm going to talk about some of the things that we got involved with through the GP Forward View. But we got some resource. We got this Productive General Practice programme came along from NHS England, and it was really welcome. We grabbed things with both hands. And we did 2 modules. I don't know if any of you have been involved in these things. Did something on workforce planning and then something called Chasing the Tail. And it was really useful. So that workforce planning, let's talk about that. We were finding that there were times in the year where we were really short of GPs. And so we started to map it out. So we did this at the beginning of 2017. So this was done retrospectively. And we tried to work out, well, how many sessions of GP time do we need per week in our York practices? 33,000 patients, 6 sites. What does that mean? And there's all sorts of measurements you can use, and none of them are particularly accurate, I think. But when we went to Hull, we got an APMS contract, and there was a KPI in that contract that said we needed to provide 16.4 hours of GP time per 1,000 patients per week. Don't know where they got that from, but it kind of worked, and it was a good figure to be aspiring to. So that was for a practice that was open 8 till 8, 5 days a week, plus 9 till 1 on a Saturday. So we pared that back to the 8 till 6, Monday to Friday, and that worked out at 50 hours a week. And when you took the 16.4 and extrapolated it back based on those numbers, it comes to 15 hours per 1,000 patients per week. And if you multiply that by 33,000 patients and suggest that a session is 4.2 hours, that comes out at 118 sessions. You'll have to trust me. You can do the maths if you like, but it's about right. So that was our benchmark. That's what we felt we needed to deliver to be safe. And if you look at this, when we looked at it retrospectively, these are all the school holidays when we dip below that line. And this purple line are our registrars, and the green line were locums. Okay? The reason we had locums was because being a big practice, lots of doctors, lots of maternity leave, there were maternity leave locums, okay? So what you can see, what we concluded was that we're sailing pretty close to the wind, and we're relying on registrars to stay safe. So it highlighted the problem. We haven't got enough clinical doctors. We haven't got enough doctors in our system. We need to do something about it. So we did something about it. And this was the exact same thing for 2017. The colours have changed, and I apologise for that. But the blue is our registrars, the green are locums, and this was actually internal cover. So I think we were filling some of the locum cover with people who were coming into work on their days off. But the real learning point was we got more doctors, so we weren't sailing close to the wind anymore. We weren't relying on our registrars. We planned our holidays, because before we didn't have a system for planning holidays. People were just putting in leave and they were going. And we had some rules about who could be off at any one time. And that sounds fairly basic, and you think, well, why weren't you doing that anyway? But we weren't. But the data showed that we had made a difference, and it helped us to plan that year, and we're doing it this year, and we'll do it moving forward. So it really, really helped. The other thing we did was chasing the tail. So this was looking at how many times do people attend for a GP appointment in a year. Okay, so there's the zeros on Dont here, but there's a huge column of people who don't come at all. Out of our 33,000, there was 4,500 who came once, and you can see what happens. It gets fewer, but wow. And guess what? This is only page 1. I haven't got page 2, but this goes on right over here, and we've got a patient who came 140 times, and there's a whole load of people that came more than 100 times. And so the idea was, well, let's look at those people and see what we can do to see if we can stop them coming 100 times or more a year. And you know what? It was really difficult. We did some multidisciplinary meetings where we looked at their clinical notes, and these guys at that end, they've got real physical, psychological, social issues that can't be solved by us just sitting around a table and deciding that we're going to do something different. We had to engage system-wide support, social services, social prescribing, and that's a real long-term effort. But it just shows you that you come up with these plans and you think you can make changes really quickly, and you just can't. It takes a system-wide approach to addressing these people who are coming 100 plus times a year. So I get on to the stuff we did internally on workforce, and this started with a real simple time and motion study. Simple questionnaire that we gave to all our doctors. So it was done for 20,000 patients, 4 sites, about 19 doctors. And what it showed us was that we were spending 60 hours a week doing admin tasks. Another 60 hours doing reauthorization of prescriptions. We were going to loads of meetings and we spent 66 hours a week doing home visits. And you think, well, okay, home visits is core general practice, but we'll come back to that. Do we need to do all of the home visits? We weren't getting much time for lunch. The days were pretty long. We were in this culture of turning up at 8:30 in the morning or 8 in the morning, getting on the treadmill, running it 100 miles an hour till you decide at some point you can get off and go home when you've had enough. It's 6:30, 7, 8. There's the GPs. It can be late. So that was where we were. And we decided this is not sustainable. You know, this is not attractive. People don't want to do general practice. This is pretty tough. And there's things that we do in there that actually other people could do, other clinicians, other professionals could do. So why don't we try and create a situation where GPs are only doing things GPs need to do. First thing we did was looked at letters and admin, so productive workflow. This is one of the high impact actions. Yeah, we were getting over 10,000 letters a month. All right, I don't know if you've ever counted that. So these are coming from secondary care, from all the third parties. That's 10,000 letters, and they were all being looked at by a doctor, and they were being deciphered by a doctor and sometimes coded by a doctor, and then the actions were being done by the doctor, and then the doctor was filing it in the patient's notes. So we decided, actually, I don't need to do that. I don't need to see the letter from A&E that tells me that one of my 21-year-old patients has sprained his ankle playing football and he's fine. I'm not going to do anything with it. I'm going to look at it, I'm going to file it, and I'm going to instantly forget it. So why am I looking at it in the first place? So we devised this really simple, that's one slide protocol. So clinic letters with no action, letters for adults who DNA'd appointments and had subsequently been made another appointment, ED out of hours attendances with no action, the 21-year-olds who sprained their ankle, and then any letter with a prescribing action would go to our pharmacist. I'll talk about pharmacists in a minute. By this time we had a pharmacist. And we brought this in, and overnight it reduced the number of letters that come to doctors by 2/3, which felt really good. And then you think, well, okay, so what? What does that mean? Well, and there's a few assumptions here, but if you say it takes 30 seconds to read, digest, and action a letter, then per month, that was saving over 30 hours of GP time. That's 6 to 7 sessions a month. What it's doing is taking pressure off us. It's making our day feel less cluttered. It's giving us more headspace. It's allowing me to turn the treadmill down a couple of notches. And it feels good. So then we thought, well, what can we do to the workforce? We know that we're doing all these visits. We know that we're doing all these prescription reauthorizations. We know that we're doing a lot of urgent care. And when you're busy and you're sitting in your surgery and you're thinking, I'm very pleased that this person's come to see me with the uncomplicated viral upper respiratory tract infection, and I'm very happy to see them. But actually, in the context of everything else I do, I think someone else could see them just as effectively and just as safely. So we started thinking about all these things. And at the same time, Health Education England, but Health Education Yorkshire and Humber came up with this kind of model. Have you come across this? This inverting the Toblerone concept. So the concept is that traditionally, general practice looks like this. You've got a ratio of 4 doctors, 4 GPs, to 2 practice nurses, to 1 healthcare assistant. And the idea is that if we're radical, we can flip it. We can invert the Toblerone so that you have 1 GP to 2 advanced practitioners to 4 healthcare assistants or nursing associates. Okay? So we looked at that. We thought, well, that's pretty radical. Well, let's maybe go halfway. So for me at Haxby, I thought we could get 3 to 3 to 1. This became our workforce strategy. So right back here, this is 16, 17. I looked at what we had, and we'd already started doing some of this. We got pharmacists, we had a few nurse practitioners. We had 3.4 to 2.7 to 1, and my target was 3 to 3 to 1. And you can see that the bar charts don't look very different. You can probably see that goes down and that goes slightly up. This is the cost. Okay? Well, the point is it goes up. And the reason it goes up is because these people need mentorship and support. And there's a hidden workload to taking on multi-professional teams. but it does go up. And then once you've got the team stable and working, you can then start to think about taking your doctors from 3.4 to 3. And actually where you end up, and this is a model, I accept that, but theoretically where you end up is with the cost being less than it was when you started. So that's the journey we set off on. So we now have 8 pharmacists. What you have to imagine is before this point, there's a point in time down here when that blue line was the blue line plus the red line. Okay, so the data's not on the graph, but at one point in time, GPs were doing all of this. And what you can see is that the blue line, the blue bar gets smaller and smaller, so that 60 hours a week is now maybe less than 10 hours a week doing prescription reauthorization. What you can also see is that the pharmacists are doing more. So they've come in, they've got capacity, they're doing the job well, they're now seeking out cases, they're now going into care homes to do this proactively. So they're doing more than we ever did before. This is urgent care. We decided to trial an urgent care system where all the patients who requested same-day appointments were seen by a nurse practitioner or a paramedic first. And they would see them and see if they could deal with them. There was no telephone triage. If they felt they were inappropriate or they couldn't deal with the problem, there was a doctor free from all clinical appointments to supervise that team, and they would see people that they didn't feel happy to see. So it was safety netted, it was supported. These people were being, we didn't really know how to mentor or support these people, but we based it on how we do it with GP trainees. So they had a mentor, a trainer, they were debriefed after every surgery, they had tutorials, they have tutorials. We just modelled it on that. And we trialled it in 2 sites that look after about 13,000 patients. And right at the beginning, the red line is the number of urgent care appointments seen by doctors, and the blue line is the total number of urgent care appointments seen in that surgery. So we're seeing about 400 appointments a month. And you fast forward a year, and pretty much all of these urgent care appointments have been seen by nurse practitioners and paramedics. And these are people we've recruited with minor illness experience. They're all on the master's course at the local university in advanced practice. They've all got GP supervision and mentorship, and it's working well. Now, what's not shown on there is that there are patients that they see that they need help with. So they discuss about 10% of those with a doctor, just discuss, chat, and then a further 10% are reviewed by the doctor physically. But that's freed up an awful lot of time. We had, at the beginning of this, we had 7 doctors working in these 2 surgeries, and the system we had was that they'd spend half of their surgery seeing routine patients and the other half doing the urgent care. That doesn't happen anymore. There's a rota where one of them every day is the urgent care doctor. We have our registrars that dip in and out of it because they need to see urgent care as part of their training. But the rest of the guys have got more appointments to see routine patients. And look at that. That is the biggest consequence of this. So we were doing 12-minute appointments. Now we have 15-minute appointments. We were doing 14 12-minute appointments. That was our standard surgery. We now have 11 15-minute appointments. So the surgery length is the same. We just have longer with each patient. And yeah, we don't get the catch-up appointments. You don't get the quick, uncomplicated UTI that you can see in 5 minutes probably. We don't get that anymore, but we've got longer and fewer. And it feels good. Feels good. We did have patients involved in the process. The PPG was involved. We used social media to engage them. So that did happen. This pie chart that you can't really read, that just tells you that that's all the different types of clinical condition that these people are seeing. It's vast, you know what I mean? It's like an urgent care clinic that you would be familiar with if you were a clinician in this setting. So that felt good. That's the patient satisfaction questionnaire of people who were seeing these clinicians. So patients like it, because that was one of the things that was holding back. You get the, you can't do that because patients will never adapt to that. They won't like it. They want to see doctors. Well, guess what? They don't. And what we've seen is that when you take a paramedic out of an ambulance and put them in a primary care clinic, a GP practice, and say, crack on, that's not going to work. They need time to understand the role, understand how it works, understand the system. They need clinical supervision, mentorship. They need to improve their examination skills, etc. We found it takes about 11 to 12 months to get them from the back of the ambulance to the point where they're seeing urgent care patients in 15-minute appointments with the same reconsultation rate as doctors, the same out-of-hours consultation rate as doctors, and the same admission rate. So a year. There's a year of investment where you're perhaps putting more in than you're getting out. But the end product, I would suggest to you, makes that worthwhile. And that's why the cost is going up to begin with, because you have to have that GP time and support. And then we started thinking, well, we know home visits are taking up a massive amount of our time. Paramedics, their natural environment is the community. They're very used to going into patients' homes. So why don't we start to use them? And there's lots of areas around the country that are doing this. In our area, we had a CCG scheme that we used for a little while, and it had variable success. The difference with this is that the paramedics were part of the general practice team, part of that primary care team. And we created a protocol for the people that they were able to see. The visits were triaged, and we briefed them before they go on visits, and then they get debriefed when they come back. They have a phone number of a GP they can ring if they go to a house and it's not what we were expecting. So look, this is March 17, so a year ago. These are the home visits that we were doing, and you can see, you think, well, that's just seasonal variation. That's summer, that's winter. That's what you would expect, I think. We introduced the paramedics doing the home visits, and as they got more confident, that's gone up, and of course, GPs have gone down. That's about 70% of the home visits, and the average number of visits we do has gone down as well, because we're now triaging the visits a bit more actively than we were before. So the QI culture has helped us to drive that. It's helped us to measure it. When we put them in, the team said, look, this is what we're trying. It isn't going to be perfect on day one. We've got data measuring it all the time, and we'll tweak it and change it. And we've done that slightly. We meet every month as a urgent care team, have the data. We get quantitative feedback through the data and qualitative feedback from the people that are doing it. And you make changes as you go along. This is really interesting. So the non-clinicians, the business intelligence team, are having a direct influence on patient care. And there's good evidence that that actually helps. Scale has helped. I'm not going to say scale's right for everybody, but for us it has helped. The business structure, the revenue streams have helped us invest in the workforce. But actually the point is that the data demonstrates the need and drives the service development.